webinar, we should be on the webinar for about between a half an hour and 45 minutes this morning. It depends how many questions that you have. Right now, we have everyone on mute, but at the end, I have about 10 slides I'm going to go through to talk a little bit about the system design clinic that the Georgia Alliance to End Homelessness has asked us to come and provide across the state of Georgia for Continuums of Care. And so then at the end, we'll open it up for questions. In the meantime, so actually let me go to the next slide. So right here talks a little bit about what you can see along the side, and you can see you have two options. One is for telephone, one is for your mic and speakers, and some of you may be on both ways. My suggestion, you can ask questions right now by submitting questions in the question panel and sending them in, and then I can answer them at the end. But when I unmute everyone, or my colleague Anna Blasco has joined me, she's managing all the logistics of the webinar. So if you are on your mic and speakers, we're not going to be able to hear a question that you ask, so you really should do the telephone. So if you've already joined through the mic and speakers, but you think at the end you'd like to be able to ask a question and be part, of the dialogue when we unmute everyone, you can just dial in and use the telephone option to do that. So that being said, I want to move ahead. So a little bit about the System Design Clinic. So the Alliance has put together and has been offering these clinics that will go into continuums of care across the United States. We first started doing clinics when the HEART Act first came out, around the expectations of the HEART Act. And this is like the third rendition of a clinic. And what we do is go into local communities' continuums of care. And so why a system design clinic? A little bit of the overview. What we're going to talk about is solutions, strategies, and resource allocation to end homelessness. We're going to go over a design for what best practice crisis response system is. As the Alliance has worked with communities across the nation, we're looking at those communities that are reducing homelessness, significantly reducing homelessness, have really changed practices, moved away from traditional interventions and trying new approaches and shifting resources, and are finding that there's significant changes happening in their community. So we will come in and share information to all of your stakeholders to get everyone on the same page. And then one of the pieces that's huge in the new regulations that have come out since the HEART Act is a critical role of governance. And a lot of times we find that providers aren't clear and understanding that there is a huge role of governance, and that the Continuum of Care leadership has a big role in governance. So this is an opportunity. We use this opportunity, and we find that sometimes coming from another organization like the Alliance, that folks can hear it more clearly than they can hear it from their own leadership, is to really support you all as Continuum of Care leaders in the work that you're doing and your role in governance, and how everything is now working as a system rather than individual providers. So a little bit about the way the clinic is set up. This is not about huge amounts of in-depth planning. This is not technical assistance. I know probably a number of you in Continuums of Care, and I know specifically some of you have had a lot of HUD technical assistance, have been doing huge amounts of work within your Continuum of Care. The clinic is more of a, I call it a higher level overview. It takes place over 1.5 days, and it brings together the key people in your community that you as Continuum of Care leadership want to make sure that folks are hearing the same message. And we'll talk about best practices and we'll do presentations, but there's just a lot of activities to get folks, particularly providers and key stakeholders, to really be involved in understanding what is the best practice system design, and what might be some of the modification that they need to start thinking about their programs to align with the best practices. It really, if I would be able to sum it up, that what we've heard and the feedback from all the communities that we've done this in is that it really provides an opportunity for all the membership, those that you invite for the Continuum of Care, to hear this one message about how we need to really start thinking as a system and strategizing as a system, and this importance of the right resource allocation that goes to the most effective and efficient best practice interventions to end homelessness. We know that there's, a lot of changes, and all of you have been really working on a lot of the changes, and that change is really hard for a lot of people. And so the Alliance put this together to really support Continuum of Care leadership and really moving practice forward, and allowing an opportunity through some really interactive activities with the participants to really understand and realize the importance of doing all of this. Now, what I want to say, and I've talked with Catherine a bit about this when the Alliance contacted us about doing the clinics. Traditionally, the way we do our clinics is that often we're contacted. I can't talk this morning. I probably need more coffee. But we've been contacted usually by one or two continuums of care and by the actual continuum of care leadership. And we will, most of the time that we've done the clinics, it's been for like one continuum of care. Sometimes in a region, 2 or 3 will come together to bring the clinic in. This is one of only the second time we've done it more from a statewide approach, where there's been a state organization that's been inviting people to come to the clinic. So it's a little bit different because, normally before we are even doing this webinar, I would have been speaking with each of you in some pre-planning calls even before the webinar about, what you're looking for in your community, how it can benefit your community, and then we do the webinar to sort of have a kickoff and figuring out what we need to do next. So today, because it's a little different, I'm actually going to be talking about a few more things and have a few more slides so that you have an understanding of what the clinic is and how to do that. I will say that we did do something similar recently in the state of Virginia, where the DHCD, the state organization that has a lot of funding, sort of like Georgia's DCA, sponsored through a grant that we had and also the Virginia Coalition on Homelessness and the Alliance had a grant that we've been working on for 3 years, and the decision was made that DHCD thought it would be good for us to come and do clinics across the state. And so we again did regional clinics. There's a lot more continuums of care in the state of Virginia than what you have in Georgia. And so we did something similar where we brought together several continuums of care, and it wasn't driven initially, the request didn't come from the leadership, but rather we had to take a few steps back to get everyone involved. But we found that it was really, really effective. We got a lot of good feedback from the folks, even folks who had been doing a lot of work, and a lot of TA felt like it was just a good time to sort of, have a day to come together and start really thinking about some things again and just refocusing and getting everybody to hear the same message. So that being said, a little bit about who needs to come to the clinic. So the clinic is divided. It's a full day, like a 9 to 4 day the first day, and then the second day is just a half a day. So the purpose of day one is who are those key stakeholders, and this is not for the ground level providers. They will have an opportunity to fill out some surveys, but this is really for your homeless service providers, the leadership, the high-level administrators, the persons that would have the ability to leave a clinic and say, we need to start really rethinking what our program does if we want to align ourselves with the direction that the continuum of care is going in. So it needs to be the decision makers that you would want to invite, not so much the actual frontline case managers or even program managers, unless in a, now, say for example, you have a provider that has a ton of different types of services, and homeless services are only one of them, and there's a program director or division director that makes the decision specifically around those services. So then, in that case, you might want to invite the program director. But if it's an agency that, that what they do is provide, for example, transitional housing, then and that's all they do, then you would really want the executive director to come, because they're the one that's going to have to look at a shift in practice and perhaps mission to really align with, all of these new, the hearth objectives that have been around for a while, but that, sometimes providers are still sort of trying to figure out how their program and their mission and what they've done for years fits with sort of the new direction that the Continuum of Care may be headed in. And then your Continuum of Care leadership, whoever your obviously your Continuum of Care lead, folks that do the work, I call it, the Continuum of Care worker bees, funders of local homeless services like your United Way, Emergency Shelter Grant. By the way, this is not just about Continuum of Care funding. This is about your system as a whole. And so, any significant funders that have the ability to really support the services that you provide, it's going to be really important to have them there. Your mainstream leadership, like your public housing authorities, your TANF folks that you want to really bring to the table. It's important to have your HMIS administrator there. And I know, so you guys might be using a statewide system. Again, remember that we go into many different communities and everyone does it different. But who is the person that needs to, get information out of the HMIS system? Those are the people that's important to be there, because we're going to really, at the clinic, we talk about data, and we give an opportunity for you guys to fill out the evaluator tool that we're going to be able to do some analysis that, though you and the folks that are there will be actually able to see sort of what your data in the HMIS system is currently telling you. So that's why we would want an HMIS administrator, whatever system you use, however you do it, just whoever is the person that can get the data out of your system, that can be able to give reports and understand how important it is to get that information to the Continuum of Care leadership. One of the things we've learned is that there are maybe some really critical providers that are in your local community that are not at the table, that have that can really impact what happens in homelessness, like those in the faith community. As an example, we've been in communities where perhaps there's a large mission that does a predominance of emergency shelter, but because they have never gotten any state or federal funding, they haven't really been that participatory. But as you know, as we look at a system, it's important that a system needs to look at everyone, even non-funded providers, to really be part of the process and looking at the system if we're going to end homelessness. So are there some folks that you'd like to really hear about sort of the message that and an understanding of why you as the Continuum of Care leads are heading in a certain direction that you'd want to invite? And then your governance, like who is your decision-making committee membership? Every community, every Continuum of Care has their own decision-making committee. The main thing is the HUD regs say you have to have a specific appointed or designated committee that makes decisions on behalf of the larger Continuum of Care. And so whomever those folks are, having them be there. And then day 2 is going to be just your decision-making committee membership, which allows the folks that, that are part of that committee to reflect on some of what they've heard the day before, and then to really think about, and what we really do is we talk about the collective impact model and how all the things that HUD says you need to do under governance, and how that really can fit well with a collective impact model, and just ways to really be able to communicate that again to your larger Continuum of Care. So the day is, and I don't know that I have this on here. Look at me. Yeah, I went back to this slide, the third bullet, where we talk about a lot of group activities. This is really a lot of interactive kinds of things to get people just to start thinking in ways that can really support the work that you're doing to move forward, and helping individual providers, sort of individual stakeholders starting to really see the importance of their role in thinking of how they need to be part of a system, and work in a systemic way. And that's why we call it the system design clinic, because, you know, we have to sort of really move away from a lot of providers doing individual things and start really looking at the overall system impact and what does, you know, how does that individual provider's work impact the system, and how may they, you know, each individual provider start realizing that they need to start really looking, especially with coordinated assessment. You know, the Continuum is now setting performance standards and prioritization standards and looking at eligibility, and so that messaging that it's not about a bunch of individual programs anymore, it's more about how we work together as a system. So here's the stuff that we normally focus this particular webinar on, is this performance. I went over the other things because I had not had an opportunity to talk to any of you individually prior to this webinar. So this is the meat of what we normally do in the webinar. There's two things that really make the clinics impactful for your local folks, and to just help you all as you come out of the clinics and continue the work that you've already been doing. One is that there's a tool called the Homeless System Evaluator tool. That tool is on our website. We've had it up for a number of years. Anyone can use it. But part of when you participate in a clinic, we actually will have you fill out the tool, but then we actually get that tool and start really looking at it. And when we come to the clinic, for each of your continuums of care, we will have data. So it's not going to be congregate stuff. All the work that we will be doing, for example, I believe if all the continuums that have been invited participate, for example, in Savannah, there will be 5 continuums of care. You will work together as an individual continuum of care. You know, we'll do presentations, but then any activities, any work that happens is going to be specific with the folks from your continuum. Will get together and work with each other, so that it's not like one, you know, everybody, you know, working as across the state. You have that ownership and that individuality of what's going to work best for your own local continuum. So the System Evaluator tool is filled out specifically for your continuum. And when we do the presentation, we will bring back some slides that come specifically out of what does your data tell you, and what are some trends that the tool is showing you. This is a tool that was put together for us and has been available that communities can use. But one of the things that we find is that by us pulling some things out, we can really, at the clinic, help you all look at some things and give you sort of an understanding of some things. So there's 3 things, and then I'm going to actually click on this link to show you the tool. So there's 3 things that you need, and this is why we wanted the HMIS, you know, when we said your HMIS person should be on the call, because probably your HMIS person is a person who's going to take a lot of the responsibility to fill out the tool, and you'll see when I open it up, because there's information that you need to have that comes specifically from your HMIS system. But you'll need to have your last 3 point-in-time counts. Now, I know you all just did your 2015 count, and by the time we need this back, you may not have your final numbers. So you'll see when we get the tool to you. Now, the tool we open up is still going to even have later dates on, but we're going to be updating that for you. But the most recent point-in-time count information we're going to ask for is 2014 information. Even though you may have the 2015, we know that that's not due to HUD, and a lot of people are still, you've just come out of your point-in-time count, and you need time to really make sure that your number's correct. So you don't need to worry about doing that before you fill out the tool. The 2014 is fine. So it will ask for data for your last 3 point-in-time counts. It will also ask you for data on your last 3 AHAR reports that you submitted. You'll need information from your housing inventory chart, and information from your most recent APRs, and then there's information that your HMIS administrator can pull for 1 full year, and you can pick whatever year you want. My suggestion would be that you just pick the complete 2014 year and have your HMIS administrator pull the data for that year to put in the tool. So now let me pull up this tool. So this is going to take us to our website. So this is, if you go to our website, this is what you'd see. And I don't know why it's flashing like that, but that's sort of interesting. So hopefully you won't get freaked out by that sort of psychedelic flashing that's going on my screen right now. Okay, so Anna's here to try to resolve this. Hang on a second. Thank you. All right, so now we're good. So I've just pulled this up right from our website. So in the beginning of the workbook, this is an actual Excel spreadsheet, and in the beginning there's instructions. And the next two things are going to show graphs, which right now there's nothing in these graphs because there's no data on this one. But what happens as you folks add your data in under these, and the other thing I should say is that whoever's going to fill this out, you only fill out the things that are yellow. Now, actually, this one should show yellow. It's not showing right now, but when you get your tool, this will be yellow as well. But whenever you see a green tab, that's going to be an automatic population. So I'm just going to go to this population summary page right now. So hang on, I need to push something over here. All right. So what's going to happen is take this to the top. So here's where you can see these years, and we're going to update these years to say 2012, 13, and 14. And this information comes directly from your point-in-time kind data. So somebody just needs to enter right out of your pit the number of unsheltered singles for each one, and in each of these categories. Again, nothing goes in the green. That will be automatically populated. And then this last one is going to be the information on the percents that you would, the subpopulation percents. This is all things that get entered into your HDX. So I'm using sort of those terms, assuming that someone, either you as leads or your HMIS people that put this, get this in HDX to HUD knows what we're talking about. But all of this information comes directly from that. Now, this information under number 3 comes from your AHAR report. And out of your AHAR report, one of the things that your AHAR report pulls is the length of stay of all of these populations. So again, you take that information directly off and you're going to dump that into these yellow categories. This next slide, that most of this information now is going to actually come from your HMI or your HMIS system. So here's where you would put your information in from your point-in-time capacity count. So for all the shelters, how many total beds do you have for singles in shelters? How many total beds do you have for families in shelters? And then out of your HMIS system or your AHAR, but you can pull this out of HMIS, is the total number that were served in each year and then the total number of exits. And then what we're going to be looking for is all the exits under each of these. So the strategies we're looking at is shelters, transitional housing, rapid rehousing. If you still have SSO programs, we know most communities, many have closed down SSO programs. If you still have them, enter that information in, and then permanent supportive housing. So it's your main homeless assistance strategies, and this is all aggregate data. Now, the reason this is so this you can pull out of your HMIS system as aggregate data. If, however, it's not easy to do that, and it's easier for you to do it as individual programs, you don't have to do both sheet number 2 and number 3. But number 3 allows you to enter every single program in your system and put their, instead of aggregate data, it puts their individual information in. Does that make sense? So, if you have a question, you can ask. But this is aggregate data that you can put in your system if you want to pull it as aggregate data. And if it's easier for you to pull it as each individual program, you can leave it here. You can do this, however, as long as you know who program 1, program 2 is, we don't need to know who your different programs are. One of the benefits we've heard from some communities that have done this is that one of the things when they do it, even though we won't talk about this in the clinic, as individual providers, it can actually help you sort of see, are there providers that are actually doing a better job of exiting people to permanent housing than other ones. So it just may give you more information, but it's nothing that we'll use at the clinic. So now I'm going to go to the sheet that's probably, again, going to be the hardest one to do, and this is where getting budgets for your programs. And so this can come from the AHAR reports, but obviously under emergency shelter you don't have AHAR reports. And the other thing with program budgets is that, in fact, your APR often just shows what your grant is from the Continuum of Care and maybe the matching dollars. But, for example, I used to run programs, right? And so I had a program that I ran, but the whole program, my actual cost to run that program for everything, my overhead, office space, everything for that program was about $300,000. My grant from HUD was only $115,000. My match, obviously, it was a 20% match, so that 20% match was whatever. I can't calculate that right now, but maybe $22,000. So my AR sometimes just showed that. Eventually I changed that, but in the beginning I only reported to HUD specifically on their information. However, when my community, before I worked at the Alliance, we actually had a clinic similar to this. We actually filled out this evaluator tool for our community, and so we actually went to each program in our community and really worked with them and got their total budget. So, so my whole budget was actually $300,000. So when we did this, we had just put in what my cost was for my HUD stuff and what I was using. It wouldn't have been reflective of what it was really costing the community to run that program. So what you want to be able to do is get this information as much as possible. And I can talk to talk to you further about this and more individually about some strategies of how you get this information. This is the most valuable information that you can get because it really starts helping you see sort of what the bang for the buck is for the community. And this is one of the things that we've learned that most communities haven't done yet. And we find that it's like one of our continuums said down in Virginia. They had actually had a clinic from us previously, had a lot of TA through HUD, and had also brought in some other consultants just on their own outside of HUD. But one of the things they said after looking at this evaluator tool a second time is that what they realized is that they were putting a lot of data in, and they were even sort of looking at data, but when they started looking at the cost analysis, it's for the first time they started really using this information and the data to make decisions about allocations and reallocations within their community. There is a sheet here that talks about your tips for how you might want to estimate some costs, but if the more you can get your cost to perform, or your number 4. And by the way, I'm seeing this, I pulled this up from the website. We're going to actually have to make this because this is, this should be a yellow because this is one of the things that we are going to need information on. However, what's going to happen then is once you get your budget in, you don't have to fill this out. This is going to pull things over from your you want to either sheet 2 or 3 will get dumped into there, and then your costs will get dumped into there, and then we're going to actually be able to pull some information from this. And then the last thing is the system entry analysis. If in your homeless assistance system, your HMIS system, you are collecting data on folks that get prevention dollars. And the reason we have HPRP up here is that we find that for some communities they haven't put any prevention information in since the days of HPRP, but they actually have some prevention information. But what we try to do is look across, a year and look at the total number of persons and families and singles, and that a prior living situation, which is one of your data elements that you have to have in your HMIS, is so again you would just pull this information out of HMIS for 1 year and find out where those folks are coming from when they come into the homeless system, like this would be coming into emergency shelter, or if people are coming directly from the streets into a transitional bed, looking at that. And then you look at where folks are coming from when they get prevention dollars, because you also need to include that. If you don't have that data, then we don't use it. But if you have it, it also really helps you think about sort of that front door and prevention. So I'm sure all of you right now are looking at this and like going, oh my gosh, this is like really confusing, and that's why I'm willing and will be available to talk to folks as they open this up. I think the best thing to do will be we'll send you the link out, and we also are going to set up drop boxes for each of you. I'll be working with Catherine to get your email information, and either through me or through Catherine, we will be sending you these links and this information so that you'll be able to do some of this for your continuum of care. And then once you're, you or your HMIS person, you sit down together and take a look at this, when you look at it on the screen, you can get very overwhelmed, but we find that if you've got your data and have pulled it, we've had communities, that if you have a good, you as your, I'm assuming HMIS folks are on the phone call, and a lot of this may look pretty familiar to you. You already have your reports, your point time count, and your AHAR, and so you just start dumping the information in, and it actually starts getting sort of interesting because, once you start putting it there, you can actually start seeing things, and we're finding that folks, once they start doing it, it's not as overwhelming as when you actually look at it. So we will, again, if you have questions about that, we'll talk about that later. So I'm going to get out of this now and move on. So the second thing are going to be, there's 3 sets of surveys. So there's going to be a set of surveys for your community leaders, a set of surveys for your providers, and a set of surveys for your consumers. So here, and I'm going to give you I have the date here 3 weeks before your clinic, but I'm going to actually give you dates for this, so don't worry about any of that right now. So in the surveys, we are going to send you links, and again, each continuum will have your set of surveys. So that's why we need to know, and we will work with the Alliance, the Georgia Alliance, to make sure that each continuum gets the links to your surveys. But the 3 sets of surveys you need to think, and this is a way that people that can't come to the clinic, that aren't able to come, and I understand from Catherine that there will be a cost for folks to come, and so, hopefully that won't prohibit folks from coming to the clinic, because if they can get there, it's going to be much more helpful for them to be there. But this allows folks that aren't there, because, and again, since we have to limit how many people that you're going to be able to invite due to the space capabilities in a clinic, you're going to want to really start thinking about who you see as your community leaders, and then all of your homeless assistance providers and your consumers. So let me talk a little bit about the leader survey. So the leader survey would clearly, you'd want that to go to sort of all of your, your governance lead. Who are the leaders? Who's your leadership within your continuum of care? If there's also significant leaders within your community that from your, local government that you really think should have a good understanding of what's happening in your homeless assistance system, and you see them as leaders in your community, you would want to send that survey to them. And when you send it out, you just want to, encourage them to complete it and just give their honest feedback about what they understand about the current system. It's all non-identifying information. This is all done through SurveyMonkey, so we're not going to know who fills it out. All we're going to do is we just get aggregate data. We can see, how many surveys have been filled out, but we don't know who fills them out. So it allows people to really give some very honest feedback. So again, a provider could do a survey, and a leader survey if, in fact, like the executive director of a provider is in a leadership role with your continuum of care, is on your, your governance board, then that provider, but only the executive director would get that. If your executive directors are not part of sort of the leadership, the decision-making within your community, then you'd send them the provider survey. What I want to say about the provider survey is, say, for example, you have 25 providers in your community between your permanent supportive housing, emergency shelter, transitional housing providers. You wouldn't want to look at getting just 25 provider surveys completed. When you send it to the provider, you want to encourage that provider to have every staff person providing services in their program to complete it. So one provider, for example, could have 15 people if they have a bunch of case managers, and even if there's if a provider uses volunteers in a sort of staffing position, they could have a volunteer fill it out. But it's the perspective from the folks that are providing the services on a daily basis, getting those providers to give feedback. So one organization, could provide, a number of provider surveys. And then the third link is for consumers, and you would want to get that link to providers who have access to either current consumers, folks that are currently experiencing homelessness, or folks that were previously homeless that they served that are now housed. And again, there's two ways that consumer survey can be done. We know some communities have actually downloaded it as a hard copy, and then they'll have consumers complete it, and then somebody on their staff will go in and enter the consumer feedback, or they'll provide the, they'll have access that consumers can actually sit, for example, emergency shelters, transitional housing providers often have a computer that's available, and so then folks can go into that link. And we, again, the more consumer survey, the more surveys you get completed, the more it's going to give you a picture of, are the leaders and the providers on the same page, and what are the things we're really strong in that we are really moving forward in, what are the things that we can see we may want to focus on. And the other thing is the consumers, the questions that we ask them are not about individual programs at all. We don't ask them about the program that they, anything about their program. They don't name the program they were in. It's just more their overall view, like, when you became homeless, did you know where to go and get services? That type of thing. How, do you know when you're going to find housing? Just to get a sense of, what their experience is. But they are not doing any information. They're not evaluating or giving feedback on any individual programs. Again, we're not going to know who the consumer is that's filling it out, and we're not going to know what programs serve them. It's just going to be a sense of sort of how they were able to access, how they thought they were able to access services in their community. So those are the two things that we get, because again, this is not just about us coming in and giving information. While we'll have short presentations spattered throughout the first day and again the second day about some best practices, a lot of this we're going to be spending some time on the afternoon of day one to really look at this information, pull some survey results. Also, while we aren't going to be able to share all of this stuff, all of this we'll download the entire, all of the surveys and get them in a PDF, and you'll have all of the survey information for you to look at and use in the future. All of this information is yours that you'll be able to use in the future. So some other materials that are helpful for us, if we see them in advance, would be anything like, your housing inventory chart, like, how many, total beds do you have for families versus singles. It just gives us the sense of, is this a system that has tons, lots of transitional housing for families, but not as much for singles, or maybe a lot of emergency shelter beds for singles, but not as many for families. Just anything like that that you have. Is not your whole, we aren't asking for your 2014 Continuum of Care application, but just your project listing. If you can share that, like what were the projects that were funded, and what was the listing that you had for the different projects that you're currently funding through your Continuum of Care. If you have a 10-year plan to end homelessness, and we don't need to have the whole thing, but if there's a summary of sort of what your goals are, that would help us have a better understanding of your local Continuum of Care. If you've done any what we call system mapping, and you have a system map that would, again, give us a better understanding of how your system currently works, that's helpful. If your governance has put together policies and procedures and you have something like that, that's helpful. And I know that a lot of you are just working on kicking off your coordinated assessment. Excuse me, perhaps you have. I'm getting ready to cough, and I tried to catch it. Maybe you've already put together policies and procedures, and maybe you haven't. And all of this is like, if you have it, great. It just, the reason we ask for it is it helps us have a better understanding of your continuum before we come. So how is this going to happen? So we're actually going to be setting up, I think I have this on the next slide, that we're going to be setting up a Dropbox folder for each participating Continuum of Care. So, and I'll let, at the end, perhaps Catherine can talk about this more again, because we're not working with you individually. At this point, the Alliance doesn't know exactly which continuums of care will be going where, but our understanding is that the There will be, the first one will be held in Savannah, which I think I spelled wrong on that slide. I had a meeting that went overtime this morning, and I didn't get a chance to go back and proof these slides before the webinar, so I apologize for that. But the first location will be March 24th to 25th. My understanding is there's 5 continuums of care that have been invited to that particular location. The maximum capacity we have is 100 people. So we're saying, so that averages out to 20 key stakeholders from each continuum of care. I'm suggesting that you would identify and invite 25 people, key stakeholders from your continuum of care, because some people won't be able to come. And it, so inviting 25, and if we are over by a couple, we can, I'm sure we'll figure out how to accommodate that. But I know that, when you sort of hold it 20 and then the last minute somebody can't come, then somebody might miss out on the opportunity. So I encourage you to have the 20. So the materials that we talked about, the evaluator tool and the surveys, we would like to have that information back by March 3rd. And the reason for that is that then allows us to pull all of this information and prepare for your clinic. And since we have 5 continuums of care that we're going to have to pull slides for and get information for you and be able to bring stuff to you at your clinic, it's going to take us more time than if we're just working with 1 or 2 continuums of care. So, and we, and that's why we usually ask for things. We give you a month to get those things done and back to us. Again, feel free to call us in between now and then or email us, and I'll give you my email address at the end that you can have. For the Atlanta location, that's being held April 22nd to 23rd. Our understanding is there's 4 continuums of care. So those continuums of care actually, and I think those are larger continuums of care, which is why there's only 4 there, and so we put the 30 number there. Again, the capacity would be 25 key stakeholders. So again, now your materials will be due April 1st. So I apologize, Savannah folks, there's not quite as much time to get your stuff to us, but again, we can work with all of you, and even if it helps to set up a webinar to work, or a call just for all the folks that are going to fill out the evaluator tool. Once you get a chance to look at it, we'd be happy to set up a call. I did that in Virginia, where we had a call after the webinar with all the continuums of care just to ask questions specifically on the evaluator tool. So like a few reminders of the kinds of things you'd need to do is at this point, you are aware of it, but, how are you going to communicate to the people that you think are going to be important to be at the clinic? Because this is really up to you as the continuum of care leads to identify the folks that you would like to come to the clinic. Who are the important people that you want to be there, and send out information and invitations to them. And then links to the appropriate persons and the appropriate stakeholders. And then I put this down, reminders, reminders, reminders. And this is what we've learned in doing this, is that you may have to, sort of have a standard email that like every week you send out to your folks to, remind them that if you haven't filled out the survey, here's the link, one for your provider survey link, one for your an email for your community leader survey link, and an email for your consumers, the providers that you want to get consumers, because, we're talking very busy folks. The survey itself will take folks only maybe 10, 15 minutes to complete. Once they get in there, and the Survey Monkey is just go through and, just, answer the questions. So it doesn't take that long. It's just, the idea of remembering to do it. So we will also keep an eye on that kind of thing, and we'll get information out in terms of how many surveys are completed from each population, so that you have a sense of how folks are doing. And like the last week of February, we would probably get something out to the Savannah folks that are coming, and then the same thing, like the week before they're due in Atlanta, the last week of March, we would probably get something out to the Atlanta folks. So we're going to try, and I'm going to be working with Catherine to get an email out to each individual continuum of care leadership by the end of the week with a way to verify that your continuum of care will participate. And knowing that by next Monday is going to be really important. And this is on the Alliance side, so that we know like how many, the surveys to get set up. and the links to get out and the evaluator tools that we're going to need to know. And then what we want to know is who the identified key point of contact is, and that's on our end, so that as we have questions as we prepare to come to the clinic, and we have questions perhaps like on the evaluator tool or something, that we know who to reach out to. And then we're going to send you a link to the evaluator tool. There's going to also be a next steps document that normally each Continuum of Care gets when we first schedule the clinics. And I did send that to Catherine, but we're going to have to tweak it a little bit again since it's a little bit different. And on that next steps document, it's going to go over a lot of the stuff I talked about today, sort of remind you of the things I talked about. And there will be links to the surveys that you can just copy and paste in emails that you send out to your stakeholders. One of the things that we're going to do is we're going to set up a Dropbox folder, and that should say for each participating Continuum of Care. Again, I apologize for not being able to proof this before I did the webinar. And if you hope, we find that that works for most folks. If you already don't have a Dropbox, set up on your, in your system, you can. You'll have a link in the next steps document that will show you how to do that. And then we'll send you a link to your own individual. And again, this will not be shared with any other Continuum of Care. All 9 Continuums of Care will have your own Dropbox. That the only folks that will have access to that Dropbox are going to be you as a Continuum of Care lead and the Alliance. Our alliance, the National Alliance on Homelessness, will be the only folks that will have access to that Dropbox. So your evaluator tool, any information you put in is only going to be accessed by our staff here at the National Alliance on Homelessness, either myself or Anna, and then whoever your point people are on your end that you invite to share that. This is not public, and sorry, Catherine, even this is not something we'd open up to the Georgia Alliance. This is just specifically what we require for our training. And we will so we're going to send you a link to the evaluator tool, but we're also going to download the next steps document and the evaluator tool there. So you're going to get it 2 ways, one via an email, and then also we'll put both of those documents in that Dropbox when we get them sent up. It's also then going to be the place that you can just download any information you think that would be helpful to us into that specific Dropbox. And then when, as Cynthia and I get ready to come and do the clinic, Cynthia Nagendra is the director of the Center for Capacity Building here at the Alliance, and she and I will be the 2 facilitators that will be coming and doing the clinics. And then Anna Blasco, who's also on the call, she also does a lot of work of doing a lot of the analysis of the information that you're going to be putting in. So the 3 of us as staff will be looking in your Dropboxes, pulling out information, and if we have questions about anything, getting in touch with you. So again, here at the end, if you have questions, here is my address, and we are recording this webinar, and that's one link that I will get to Catherine that then she can get out to everybody. So if you want to hear it again or want to share it with anybody, you'll be able to do that. So at this point, that's the end of the PowerPoint presentation. And so Anna, do you want to unmute everyone, and I can open it up to questions? And did any questions get sent in at this point, Anna?
Not yet.
Okay. So we're going to unmute everyone. Are we unmuted?
Not yet. Hold on 1 second.
This is Catherine. Hey, this is we're unmuted. Hey.
Okay, everyone should be unmuted.
Hello, I have a question.
Okay, who is this?
This is Chris Fields with the Cobb County COC.
Chris, did you say with Cobb County?
Yes, Cobb COC, that's correct.
Okay. So there's really some feedback right now. I don't know if somebody has this on speakerphone. this is Kay again. So if anybody's on speakerphone, if you could just pick up your receiver.
So who just had a question? I think because we had feedback, we're going to do this a little differently. I'm sorry. If you could press the raise your hand button on the right side console, I will unmute you. So Chris, I see you've raised your hand, and you should be unmuted. So if you want to go ahead and ask your question, we should be able to hear you.
Great, thank you. I just wanted to confirm, is the Cobb County COC put with the Metro Atlanta COC, the 4 Atlanta COCs? And secondly, how much, what is the cost going to be to participate, either by COC or by program? How are you doing the costs?
So that's actually a question for Catherine, because that's not something I know about. So Catherine?
Mm-hmm. Chris, thank you for that question. Yes, Cobb will be participating with the Metro Atlanta in the Atlanta COC, the Atlanta Systems of Care session, and currently we're looking at a cost of $100 per person. That's basically to cover the food, and a lot of it's going to be based upon how many continuums do participate. Now, if we and I'm having that's why it's so important that we know by the 1st of next week which continuums do want to participate, because that will also have an impact on the cost. And honestly, the fewer continuums that participate, the lower the cost. So because we're having to cover costs for, right now we have it scheduled to where we have access available, where we have seating available for 100 people at each one of the sessions.
Okay.
So that's where where we're coming from on that.
Can you still hear me?
Yes.
A secondary question then, the balance of state, are they in the Savannah?
Yes, balance of state is at Savannah. They are with the Savannah group.
Okay, thank you.
And I believe there's some of the providers, I think, that are going to be covered by 2 different continuums, if I'm not mistaken. So there'll have to be a decision made, on that as well by the provider, if they choose to participate in both, or if they're going to want to just stick with one continuum in participation. So
this is Kay. And again, I'm just trying to learn about, the sort of how things are in the state of Georgia. So I understand that in the greater Atlanta area, that you now have the 4 continuums of care, and it sounded like, Chris, you're one of those now. So there's 4 different continuums of care. My understanding is that there are some providers that may, some significant providers that are like important providers that may provide services in 2 or 3 of those continuums of care. So, instead of each of you, like inviting that particular person, like obviously it would only matter to have one person there. Now, one of the challenges is going to be when we do the things and the activities, one of the challenges is that would happen is, which continuum of care does that particular provider sit with? But, they could, we're going to, do things in continuums throughout the day. So they might say, okay, right now I'm going to go and sort of work with, the Cobb County continuum, but the next thing we do, I'm also providing services with Atlanta continuum of care, so I'm going to sit with them. So, but again, that's going to allow you to invite more people. Does that make sense? So, say there's a Salvation Army that covers 3 of the continuums of care. Well, rather than each of you inviting that Salvation Army to come, just, all of you sort of knowing that, okay, one of you will take that as your person, that Salvation Army, we're going to invite that person, and then that, that frees up another spot that somebody else can come to allow, more of your stakeholders to come. Does that help?
So what will be important, Kay and Catherine, in that for those organizations that have multiple COCs, is that we are able to share data across the COC. So if a provider is in the Cobb COC and maybe the Atlanta COC, and we do have at least a couple of those, county COC, then it would be important for if we all decide that organization X is going to participate in Cobb, that provider who also has their feet in the City of Atlanta or Fulton County COC also have access to that data so that they can understand as well. Is that okay?
Yeah. Now, so right now, I don't know how. I'm not sure how you collect your data in terms of within your own continuum of care. So, for example, say that there's let me just use a Salvation Army. I don't know why I'm using that, just because Salvation Armies are everywhere, right? And most communities have one. So say you have a Salvation Army, and they do Fulton County and Cobb County. When they enter data into HMIS, do they identify which, are you able to know which data, which people, or which part of the program is in your county and which is in the, or not in your county, your continuum, and which is in the other continuum? I mean, is it so that, do you know what I mean?
Yes, the answer is yes.
So do they enter it that way so that when you pull the Cobb County, it's going to show the folks that were served within your, under your continuum umbrella with that particular organization, and then Fulton County would show the folks that were served under their umbrella, but it wouldn't be the same people? Or
yes.
Is it going to be the same people?
That's correct. We would be able to separate, yes.
Okay. So, okay. And so you can, so then when you pull your data, it will be separate. At the clinics, so the fact that all 4 of you together is that, when we do the presentation, it's going to, and that's one of the things is that because, this is not just about a continuum of care. I think this is what I think is pretty cool about a whole state doing this is that we know that folks, move across boundaries and move within the state. And so, sort of seeing where one, where one continuum data is and where another one is. So yeah, all the data, each, I'll pull it up by continuum, but you'll be able to see, and again, it's just aggregate data. So it's going to say, okay, here's what the evaluator tool, the stuff we pulled out, showed for Fulton County. Here's where it showed for Cobb County. And reality is, it's no matter where we've gone, whether we've gone to really rural communities, in rural areas, whether we've gone to high-cost communities like in Alameda, California, whether we've been in communities like where I come from, Lancaster County, Pennsylvania. It's amazing how similar data looks. We all think we're sort of really different, but when we start pulling data can look very similar. But in some ways, it's a good message to see that we just find trends are happening in all of the continuums of care. So that, yes, that data will be available. And again, when we pull all the things and give it to you within your continuums, you as leadership can share that, with each other. That's going to be available for you to do that.
Okay, thank you very much.
Okay. Any other questions?
Hi, John, I see you have a question.
Yeah, I have to unmute myself now. Okay, can you hear me?
Mm-hmm. Yes.
Okay. So we have a bunch of performance measures that we're supposed to be working on for HUD, and I see that some of the information that you are collecting from us is directed toward these performance measures, but not all of them. Are this something that we're going to be discussing at these seminars?
Well, so we're not, again, you mean the stuff that's on the evaluator tool.
Okay.
So on the evaluator tool, it's asking for length of stay. And so one of the things that we do is, we're not going to go into depth. HUD just released, this summer the, all the details like getting the performance standards, right? And so you all have that. So we're just going to, what we're going to do is talk about the fact that it's there, but, you know, you are already working on that stuff, but what we find is that sometimes there's providers that still don't quite, you know, understand that they now have to be held to this performance. So part of the being at the clinic is that we're going to be setting the stage that this is happening and that you guys are already doing that, and this is what's important. On the evaluator tool, what we do is what's going to show is the current length, sort of what we're going to be able to see from the current length of stay. It's just going to show some trends and what those trends are. And so it helps folks see, and it's sort of like, here's your baseline of where you are based on what we pull from the evaluator tool. And one of the, you know, again, I keep coming back to the length of stay because that's one of the things that's on the evaluator tool. And we also, recidivism rates is one of the things that the tool captures a piece of. And again, what we talk about is we sort of set the stage for why this is so important, and that you know, this is the kind of stuff that the Continuum is going to be measuring and reporting to HUD moving forward. Did I answer your question at all, or are you more confused?
No, that's good. Thank you.
Okay. So we're not going to set what those standards are or any of that. It's more about everybody understanding that this is important, and, you know, to support the fact that you guys are moving. I'm assuming you're already doing that and working on what those performance standards will be for your community. But, you know, we're going to be talking about why that's so important that everybody buys into those standards that are set by the Continuum.
And which community are you with?
Cobb.
Okay.
Good. Welcome, Cobb.
Who else? Anna, any other reasons?
If anyone else wants to ask a question, you can type a question into the chat box, or you can press the raise your hand symbol. We can wait another minute or two. I know we're over time. I just want to make sure we get everyone's questions answered.
Looking here. And I'm sure if you have questions, please just email. This is for you. You know, we want to make sure that you know, whenever we do these clinics, we just have gotten really positive feedback from folks that have come, and I think it's because we always want to make sure it's about what you need. And, you know, while we have, you know, it's a clinic that, you know, we have sort of standard things that we do at each clinic, we still, and that's why we need the information in advance, we still tailor it to the needs of each community. If there's specific messages that you think are going to be really important that you want to make sure we're messaging to, you know, your stakeholders that you invite on your behalf, you know, letting us know that, that's also helpful for us as we prepare to come and do the clinics in your community. This is about making it as helpful as possible for you. And again, this is all about, you know, and you guys have heard this, you know, this is about moving to a system. You know, and so we call it a system design clinic, but it's not that you're going to design your system there. It's again, we're not even sure that that's the best name for it, but the idea is to really be messaging that we need to start, everybody needs to be thinking as a system now, and that how you design your system is going to have the impact on reducing homelessness, and it's just going to, you know, impact your community in every way, put you in a better position to bring dollars into your, you know, into the state of Georgia, you know, and be competitive, but more than that, because you're going to be significantly, you know, implementing the strategies that can reduce the numbers of homeless folks in your community. So my email address has been up there long enough. Hopefully you can all copy it. Catherine and I will be touching base and getting, you know, these, you know, getting information out. And, you know, we'll work with Catherine. The email will be coming from her because she's the one that's working with us to do this in terms of who's going to be participating, and we'll get that, you know, together. But eventually you may find emails if you see something, you know, popping up from the National Alliance with my email address. That would be specific, and I'll always put in, anytime I send an email, I'll just put in the subject line System Design Clinic so that you know it's something coming out specific to the clinic, because I think that in some ways we may end up communicating directly with you, because that may just, you know, help facilitate the process and make sure that we're getting the information out. Any other questions or concerns?
No more questions.
Do we hear
no one else has submitted a question.
Someone else submitted a question?
So I'm
No,
not
no
seeing
one
any.
has.
Oh, no one has.
No one
Okay.
has.
Okay, Anna, okay. Well, and I just wanted to say, this is Catherine. I just wanted to say how much that I'm available if anyone needs me. My cell phone is area code 404-401-2860, or you can reach me through email. We are out in the field quite a bit, so that's why I want to make sure that you have my cell phone number. And please, if you have any questions or concerns, let's talk about it, because that's what we're here for. We're here, to help you all and to help the systems and the collective impact of all the work that we're doing together. So,
thanks, Catherine. And likewise, let us know. Thanks for your attention and staying on this call. And it's lunchtime, so go have lunch. And I hope to see all of you in the next couple of months and be in touch with you. So thanks again for joining.
Thank you all.